Yeah, rosemary is underway. So we can probably put rosemary at the end. Yeah.
Welcome, everybody. We had 98 people register for in-person. Hopefully this will fill up in the next couple minutes. I know that the WHO is supposed to be discussing the next steps in the pandemic accord now. So if anyone is watching their Twitter while we speak and something happens, let us know, we can discuss it. So I am Sam Rick with AVAC. I'm here for sponsoring this event with Frontline AIDS and CARE. We have a great panel for you guys today talking about the implications for civil society and communities for the pandemic negotiations and what might arise from the pandemic accord. Probably everyone in this room is quite familiar with the pandemic accord, but just in case, or if there's people that are watching the recording that maybe don't know as much, just to summarize, the world came together after and during COVID, and decided to redo how we respond to pandemics globally. There was, a great success in developing a vaccine very quickly and also some therapeutics pretty quickly. Before COVID, the fastest that we'd ever designed a vaccine was 4 years. So 1 year is like way out of this world. But those vaccines and those therapeutics did not make it where they needed to go. A lot of countries didn't have access to them, both for price and for supply issues. And other countries bought up the supply that was there, eventually hoarding them, then eventually saying they'll donate them, and getting expired doses. And things were just not handled the way that they should. It is also not designed to be an end-to-end system where we have equity from the start. Equity is always sort of an afterthought. We've made the product, we can get it there, oh, now how do we get the access when it should be at the first? So this pandemic accord is supposed to rectify that. It's been 2 years of negotiation. At first, the first year, maybe year and a half, there was kind of little progress. They weren't really negotiating as such, and we're just stating the red lines. And we had a burst of progress right at the end, near the deadline, hoping to get it across, but it has not met the deadline of this WJ. Big sticking points included the negotiations on One Health and PABS, or the Pathogen Access and Benefit Sharing System. This is where a lot of the Global South countries felt that they had the most leverage. All the Global North countries really want access to that pathogen data to make countermeasures that work. And the Global South countries want benefits in exchange for that pathogen data. This is a political problem, and it's probably not the best technical solution to this problem of getting benefits where they need to go. That's where the political leverage is. Right now, there are 2 proposals on the docket, both to continue negotiations, but there's also a big concern of, I think maybe over 50 countries have elections this year. So it would be really hard to try to get this through, and then halfway through the rest of the negotiations have to completely switch tactics as administrations change and their priorities change, their positions change. So we'll have to deal with that as advocates and civil society. So here we're going to talk about what needs to change in the pandemic accord, what needs to be saved, and what the difference is between what we would ideally want and what's maybe possible politically. Great. So first I will turn to Michelle Childs from the NBI to talk about R&D and the implications of the pandemic accord in this space.
Thanks, Anne. I'm Michelle. I work for the Drugs to Neglected Disease Initiative, and as the name suggests, we're an organisation that tries to develop treatments for neglected populations living with infectious diseases. And so the reason that we were involved in these discussions, and I and my colleagues have been following this from the beginning, is that we wanted to see, as Sam said, whether there were practical solutions that could be put into this agreement that would address some of the issues that we and others face. Because we're an organisation that's based on partnerships. We recognise that there has to be collaboration between countries between organisations. And that's why for certain elements you need to have international agreements. So we started with relatively high hopes, although realistic hopes, that this agreement, particularly as people started at the beginning saying that this was to try and address some of the inequities, and one of the gross inequities was the lack of access to health tools. And so our position was really talking to negotiators about saying that it's important to focus on the production of existing health tools, but it's also important that if you want to prepare and to respond to new pandemics, that you also include collaborations and rules and regulations that can deal with the development, the making of the missing health tools. And so I think when you look at this agreement, and I think the good news is that finally the actual text of the agreement is publicly available, and I would recommend that you all look at this. I think the things that should stay in this agreement are the kind of checklist of all of the elements that you need to have kind of end-to-end research on the missing medicines or vaccines or diagnostics, the production and the supply to ensure access to the populations that need it. The less good is that when you look into the detail on many of these issues, there are still qualifiers on provisions that are talking about operationalizing equity, putting specific obligations to share knowledge, to transfer technology, to ensure that, we've talked about PABs and I know others will, to talk about how you can get access to any of the products which are developed. And I just wanted to focus on Article 9, which is an article that we have focused on a lot, which is in relation to research and development. Many other organisations, and I know a number of you here, will be talking about some of the other aspects. And I think if you look at that article, I think what is helpful is that it does recognise that there needs to be a focus on research and development and investments in collaborative networks, that you need to share knowledge. I think it's also important that it's a recognition that you need to have collaboration around clinical trial networks. Where I think there's still work that needs to be done is, for example, in relation to clinical trial networks, one of the things that I think is important is that there is a proposal to put back in some language which had been there before, had been discussed before, which is about ensuring access to any products which are successfully developed for the communities that took part in the clinical trials. And secondly, that if you want to carry out a clinical trial, and this is something that we faced, during COVID, we worked with our partners on the African continent to try to carry out clinical trials to see if we could get combinations of treatments to try to stop COVID progressing. One of the trials that we wanted to carry out was to use a combination of an existing treatment, Paxlovid, with another treatment. We were denied access to that product. And so one of the things that we wanted to see here is a requirement that if needed, there would be an obligation to share these types of comparator products for use in clinical trials, but also potentially for use for generic production. And then I think the final point that I'd make, and we spent quite a lot of time on this, and for many people it sounds a bit like a no-brainer, but we think that there should be an obligation on governments who fund research and development to put terms and conditions on that funding to ensure that health products, when they're being developed, the knowledge can be shared, and that governments have the power, if that doesn't happen, to ensure that that knowledge can be shared, and also you can transfer the technology if needed, and you can ensure equitable access. That provision, if you look at it, is in the agreement and it needs to stay. However, through the course of this discussion, although some countries have moved, there are still a lot of qualifiers, escape clauses, to try and make this not a specific obligation. And it's really important that this stays because it's one of the few obligations in this agreement where governments have the power. It's a specific lever. Many people want to have public funding. So this is something that is actionable and impactful, but it will only work if it actually is an obligation. There are not qualifiers on it, and it specifically applies to public funding that's given to both public and private entities. Thank you.
Just to follow up on a little of those things, can you talk about how you would see Article 9 in response to other articles and the specific provision on public financing? Right now it only applies to pandemic products, so they're considered pandemic products, and can you talk a little bit about the impact of that and how that might need to change to be more effective?
So, I mean, I think the reality is that although I've just looked at that one article, negotiators look at the whole agreement, and there are kind of trade-offs between different articles. And I think the reality is that things like Article 9 and some of the obligations, people are waiting to see what happens on PABs and One Health and others before they're really going to finalise this. I think that Article 9 and specifically this issue on obligations for licensing and transfer also are echoed and need to apply in relation to production and procurement, and those issues are still under negotiation. So I think you'll often hear this phrase that nothing is agreed until everything is agreed. The problem with that is that nothing is agreed and they keep on coming back to the same articles and putting more and more caveats within them. So at a certain point, I think that if they are going to carry on this discussion, there has to be a way to say, we do agree on this principle, we are going to go this far, because otherwise it keeps on going. It's not just circular, it gets worse every time they look at it.
Thank you for that lovely optimistic look where we're going. And speaking of putting a square peg in a round hole, we can joke about Dia's glasses. Let's turn to now to Dia Samarosa, who is CEO of SISTI in Indonesia and is also a pandemic fund CSO board member for the Global South.
Yes, it's at the bottom. Way bottom.
Okay, so I think agree to your last point about we look at specific areas where while negotiators are looking at it from the whole of the agreement, which I think there is a good and a bad way in that as well. Specifically from the pandemic fund perspective, now I'm using my hat as the CSO Global South board member. There are two elements. One is how inclusive this agreement is. We keep on seeing, hearing, and reading in the latest draft how not sure, how unsure this agreement is going to follow up on civil society meaningful engagement. At one point, there seems to be intent, but still it's not clear on how it's going to be done. Specifically, we can look at Article 17, where the current text keep on using words like promote, while it should be more definitive. If civil society is really going to be part of this whole process, because if this accord is based on what happened before, where there is a big enough lesson where civil society is actually the backbone of the pandemic response and its subsequent policy revision at national level. From the financing perspective, which I read last night on Article 20, I will not even begin to dissect what can be that article alone, because then it falls into questions of operationalizing money. Who will hold the money? What kind of pool will be done? And then again, who is going to actually implement and do the actions at country level? I think the current text right now is still vague. It's not, it's again unsure of who is going to manage, and does not even begin to answer who will be the priority countries. I think this is actually where pandemic fund and the pandemic accord can work together instead of being at opposite ends of one another. So of course, we hope that there will be an agreement, that it will be closed and and go into a resolution done by this WHA. But again, how far should we, where is the point that we can settle at? Where, whether it's safe enough to say, okay, let's do an operational framework between now and the next 12 months, or shall we fight for it to be done right now and make some agreement on that? I'm hoping for, of course, middle ground is a bad choice of word, but an agreement where one, social participation and civil society, civic space is really included in the pandemic agreement. And of course, integration in and clarity on financing, which are two of the biggest hurdles, I think, aside from the pathogen access and benefit sharing and all the other technical stuff. Thank you.
Yes, well, and I acknowledge that part of the problem with all of these caveat languages like promote or whatever, and also the timeline is due to the fault of my own government, so sorry for our dysfunction. Tia, can you talk a little bit more about the proposals for a new coordinating mechanism for financing and how the different funds can maybe respond to each other better?
From the pandemic fund perspective, in our last governing board meeting, we would like to prioritize our work as the financing mechanism for catalytic operation or catalytic financing for LMICs to respond for pandemic. We have reached out to the pandemic accord, the INB process, where we would like to, we as in the governing board would like to integrate both efforts and then make sure that we are supportive of the INB process in progressing to this. So pandemic fund remains a catalytic funding for low middle income countries. And the remaining, of course, will be have to be done together and in collaboration with the whole INB process, which we hope will give birth to the pandemic accord.
Thank you so much. Now I will turn to Chief who is the Zambia Country Director from here, to talk about the implications for Article 7 around workforce and other community priorities.
Thank you so much. I will start by really saying that CARE has really done a lot of work in advocating around the Article 7, and we're certainly keen to see a more explicit recognition of frontline health workers within that same article. There is reference to a multidisciplinary workforce within that same article, which is very generalized. We may think it's inclusive, but I think it can be a bit more explicit. And this is where we want to start seeing more targeted support and investment with frontline health workers. Our reality still stands that the future of the health landscape will inevitably require that the community health workers, so to speak, will still be the ones that will be supporting, especially at the last mile. We're dealing with a situation where there's dwindling public health funding in most countries, and this is coming out due to competing needs and demands. We have fragile states where there's conflict, and we also have external debt issues in these particular countries, which is really stifling the funding in the different countries. Now, this situation is actually made more complicated with the situation and rising agent need in terms of the stress coming out of the conversation we're talking about right now on global pandemics, and also when we look at climate change. So these will all require locally led solutions to be able to address the need, and even looking at the interventions that should be done by communities themselves. We do recognize that frontline health workers are the first people, respondents that are there existing in the communities. They are the go-to people. They are people that the communities trust. They are people that understand the local, context. And it's just right that, when we are dealing with issues of pandemic, for example, COVID-19 or cholera, you actually find that the frontline health community workers are the ones that really step up. So for this particular article, it's a clear cry right now and ask to make sure that they are clearly stated outside of the health workforce. The investment that the government has, I know just following from the earlier articles that we raised, there's, yes, definitely need for investment in tools for them to use. When the pandemic happens, there's information, of course, that is required, there's tools that are required, and with the COVID situation, for example, in Zambia, where I come from, and other neighboring countries, it's the frontline health workers that were there to actually support in terms of sensitization. We, of course, as the organizations like CARE and other organizations, were able to provide the PPE materials, but they are ready and willing to get in the front lines to be able to save, because that's their core. Their core is to save, provide that immediate need to save lives. And for this particular article and all the conversations that are taking place, with that clarity, it will enable governments to invest a little bit more, to create enabling environments, for the frontline health workers. For this particular article on our work as CARE, we just launched out our She Heals the World campaign, and we want to make sure that we amplify the voices of the female frontline health workers. The environment that we're working in should actually be conducive enough for them to actually be motivated to do their work. Thank you.
Thank you so much. Could you talk a little bit about what global reforms are needed to improve the workforce, and what we'd be looking for in an agreement like this? Something like, countries agreeing to dedicate a certain % of their budget to health worker salaries, or including education, anything like that?
Just say that again.
What global reforms are needed to improve the health workforce? What we want to see countries commit to?
Oh, definitely. Number one is committed public financing in terms of health service delivery. That is definitely the first thing that would like government to commit to. We also want to ensure that this funding that is being committed has to be used rightly, for the benefit of the communities that require this support. So we need to start looking at what are those, whether it's at a community level, at a national level, what are some of those social accountability tools that we need to use to make sure that the fund that is invested is well accountable. CARE International has what we call community scorecard, where we work with communities to actually see how the level in terms of service delivery within the health space will be done. So governments must be able to commit. Partnership is also important because we can't do this alone. the community health workers come in to provide that delivery, right? And the funding comes in. But I think one other element that government should also commit is around early warning systems, yeah, and also looking at aspects of anticipatory action. The frontline health workers, like I say, they have the knowledge and information, but they are not sitting at the table. And I was talking about locally led programming, locally led solutions, locally led information, because we need to ensure that even with our She Heals the World campaign from CARE, I was speaking about elevating the voice of female frontline health workers. How can we ensure that the structures at community level are actually bringing in the women's voice? You know, that's the investment. There's also investment in terms of governments committing to ensure that there is information readily available. The health management information systems, they should be established in a way that it has to be a bit different from the way we actually do the normal delivery of health work. We also need to consider that we're dealing with pandemics. Yeah, we're dealing with COVID. Some of the works that we did during the COVID days working with frontline health workers taught us a little bit on how we can manage epidemics as well. Zambia experienced cholera, and because of that learning and investment that we saw, there was a bit of a difference in the way the whole process was managed, you know. So I do believe that government may have the information, they may have the financing, but it's number one, how that information is used for proactive decision making. And also, and still back to the Article 7, ensuring that we're very clear that we're working with this cadre of volunteers at a community level that must be supported. Looking at the challenges that they may be actually facing, what should governments be able to do? That's the investment that should be. Training should not be one-off. There has to be targeted, deliberate training for managing pandemics for frontline health workers. So pretty much, if we get information right, we ensure that accountability systems are in place and the funding is in place, we surely be able to provide a good base for communities to be able to respond in a much more sustainable and of course providing that resilience to community health workers, but also communities to be able to withstand future pandemics that will come. Thank you.
Speaking of women's voices, I don't know if anyone noticed, this is an all women panel, actually, completely accidentally, it's actually quite easy to do. We'll bring now to Cindy Kalemi from panelists to talk about national accountability measures and governance.
Thank you so much for, first of all, appreciate Frontline Aids for making it possible for civil society at country level to really participate in this process. The investment that they are making in ensuring that the voice of communities is heard, I think it's admirable, and we need to encourage other partners to also ensure that country level participation becomes a priority. So we all know that any treaty that does not have an accountability mechanism is basically infutile. While we need an accountability mechanism at a global level, we also need the same at a country level. And that is where we come in as civil society who are based in country. And there are a few values that we want to see expressed in the treaty. Not only in the treaty, but also in the accountability mechanism that we design at country level. We want to see country ownership, and that includes ensuring that there is a multi-sectoral approach and participation, which is something that is currently lacking at a national level. We want to see a clear performance framework that has a monitoring and evaluation plan. as civil society, we can only be able to hold government to account if there is a system and a process for doing that. We also want to see a mechanism that is people-centered and that there is engagement of leadership, especially of most affected communities. We want to see maximization of health equity, gender equality, and human rights. If we are to develop an accountability mechanism, our view is that all these elements have to be taken into consideration. And also community system strengthening. More often than not, we talk about health system strengthening at the exclusion of community systems. Community systems are equally important. Pandemics start within communities and end in communities. A sick patient will move from the community, go to the hospital, discharge back to the community. So if we don't recognize the important role that communities play, then we are doing a futile exercise. So at Bonella, we have been implementing a program or project that is funded by Frontline AIDS. And basically this project is helping communities at a local level to be able, one, to understand what is this pandemic treaty? What does it entail? How is it going to be of benefit to me? How does it help me to better prepare for any pandemic if it was to happen? What is the role of civil society? And beyond civil society, are there any other community structures that we need to identify so that they can help us in terms of responding effectively? We saw that during COVID-19, we were like blind people in a dark room, hitting or colliding with one another because it wasn't clear who is supposed to do and to what extent. And as civil society, we are saying that we have the Global Fund, which could possibly be a blueprint on how communities can be engaged and ensuring that the voices of community are engaged, are heard from a governance point of view to the level of implementation and monitoring of interventions. If we are to build something new, it has to mirror that process because it's tested and we know it works. If we are going to integrate, we wholly support that because it's a system that is already there. And processes for engaging communities are clearly outlined. So in terms of some of the gaps that we have identified as civil society, basically are around lack of a holistic legal framework. One of the reasons it took longer to get all processes in motion was because the legal framework in itself was challenging. In the case of Botswana, we used the Public Health Act, but it was not adequate to, for instance, put people under lockdowns and what have you. We have the Disaster Management Act. It equally was not enough. So it basically shows that going forward, it's important for countries to really look into the legal framework. There was also fragmented coordination at local level. This is something that we want prioritized in terms of some of the things that we need to do. The role of civil society, like I said earlier on, and other stakeholders, they were not clearly defined. This is something that we are working on in Botswana to engage our government on how to better make some of those roles clearly defined. We are happy that after COVID, we actually had the establishment of the Botswana Public Health Institute, which was not there before. So this institution has now been tasked. One of its roles is actually to ensure that there is role clarity. We also want to see a multi-sectoral approach, as I said earlier on, to pandemic monitoring, evaluation, learning, and reporting systems. Currently, they are not clearly defined. We collect a lot of data, but how is that data coordinated and how does it add and contribute to policy reform? We've also noted that there is limited focus on behavior change in pandemic management. So this is something that we want our government to recognize and ensure that it is addressed. We also want government to also, or at least this pandemic treaty, to recognize existing health challenges and ensure that in our response, we take cognizance of that. We know that in some places, including in Botswana, HIV programs and other programs were suffering, especially TB, during the COVID-19 pandemic. So an accountability mechanism or strategy ought to recognize that there are other pandemics, and therefore we need to build on what is existing and ensuring that we sustain what is already on the ground. And lastly, we also need accountability for resources. In Botswana, when COVID, at the height of COVID, there was a public plea for people to donate money towards COVID. That was done. Botswana came out in numbers and contributed, but there were questions about how are these funds managed, who is managing them, and to what extent, and who is holding those who are managing those funds accountable. So it goes to show that going forward, it's equally important that while we mobilize resources, but we also create mechanisms for accountability for those resources. Thank you.
Thank you so much, Cindy. Can you talk a little bit, everyone talking about the level of misinformation about the pandemic report and misinformation about COVID, the way that, or the role of community in building trust in the public health system and why that needs to be supported in order to have success?
Absolutely, and that's a very critical question, because at the height of COVID, we were dealing with a pandemic of misinformation. Everybody overnight became an expert, and that created challenges in terms of sharing what the real scientific truth about COVID is. So this is one of the critical roles of communities. And I want to say communities because in my view, it transcends beyond civil society. So it's also about understanding who is in our communities and what role do they have and influence do they have on our communities. For instance, in our context as Botswana, the traditional leadership is very influential. For you to penetrate the community, you ought to have gone through them. Their word is respected. And therefore, these are some of the structures that going forward, we need to be supporting and building their capacity and giving them the right information about pandemics so that they can begin to be used to communicate the right and correct scientific information about any pandemic that we are to face. So equally, civil society have a very significant role to play in around ensuring that there is adequate scientific information around any pandemic that we may face. And also, civil society has a really big role around surveillance. And in most cases, you find that civil society is kind of overlooked. But for instance, in our programming, for us to find whether it's people at risk, it's what we ought to be engaging with the community. If not, you won't be able to find them. So working towards ensuring that the community has the right information at the right time. And I think timing is also equally important. Sometimes because we come late while we are still looking for funding, the people with fake news have already reached the people. So it's important for us to really, really prioritize capacity building around information.
Thank you so much. And last but not least, to Rosemary and Peru from Wacky Health to talk about how African civil society has been engaged in the pandemic accord thus far. Spoiler alert, not well. And before what we can try to change going forward, hoping that we'll actually be at the table for further discussions.
So thank you so much, Sam, and good afternoon. I think it's afternoon. Apologies for coming in late to the panel. I had a session that ran over, but very happy to be able to hear some of the input and the insights from the other panelists, and completely, I feel I'm very much aligned with what has been mentioned. So from a Africa civil society point of view, in terms of engagement in the pandemic accord process, I think the first thing to say is that just like in the case of civil society in general, regardless of geography, there wasn't involvement to start with. And the involvement we saw later was as a result of civil society coming together, organizing themselves and partnering to be heard. So from an Africa civil society point of view at Working Health, we partnered with organizations of colleagues who are in this room, EVA, Frontline AIDS, GPAN, and other organizations to pretty much ensure that there was civil society from Africa being heard and contributing to that voice through the Coalition of Advocates on PPPR. And that self-organization then really pushed doors and reached out and was engaging negotiators in Africa, negotiators around the world. And being able to, organize at the Africa regional level, civil society convenings, sometimes even with the Africa CDC, basically, that was leading. So there is an African civil society and Africa CDC forum that happens every quarter, and using that platform to present, our views to the Africa CDC and the processes that are happening within the Africa region led by the Africa CDC, but also ensuring that at the country level, civil society are engaging. Cindy has really given us the case of Botswana, and I would say that not many countries were as lucky as you there. I know from Kenya, I participated in the Kenya National Stakeholders Forum that was deliberating on Kenya's position, for the accord, I think maybe sometime in March. But that was not the case for all countries across Africa. So some countries, conversations happened with civil society. In some countries, no civil society at all. But at a regional level, the conversations we had were a product of partnerships with other like-minded organizations around the world. It was a product of pushing and reaching out to the linkages and the relationships that we have. So basically, it wasn't anything in the mainstream. It wasn't anything included in the design, of the conversation in the negotiations. And that's one of the things we've been pushing for, to say civil society cannot be on the margins, civil society needs to be in the mainstream. And so participating and challenging, the perspective that if you have a member state-led process, how do you as civil society then actually push for your place, in a member state-led process? And when member states-led processes come and they say, look, here, it's member states, to member states, and you are challenged, like, how do you come in? And so I think being able to challenge the narrative has also been part of how we have engaged to say, yes, it is member state by member state to member state, but the role of communities and civil society, even in that space, is very important. Going back to what you said, Cindy, that there is no global health response that will be successful without communities, without civil society. So challenging that narrative that member state to member state means no civil society. But I think it's a conversation, and we need to continue to challenge to say, even for member state negotiated processes, how can we ensure that civil society is meaningfully included and consulted? And when a number of the missteps some of the struggles and the challenges that the pandemic accord has come across, I would say, is because civil society was not in the room. If you think about the lessons we have learned from the HIV response, COVID came and repeated all the mistakes we did with HIV. COVID again went through that. I think if you look at civil society as experts and civil society are engaged as experts, both from an experiential point of view, because we have many colleagues who have experienced what it means to not have access to medicines, to not have access to vaccines, but also our own expertise by our own right. So if civil society are, engaged as experts, there's a lot that we can bring to the table. So I think our experience was just like with civil society as a constituency, no, engagement, and when it happened, it wasn't meaningful because sometimes it was last minute, and then the whole conversation around civil society not being seen as experts to bring our views, experience, and expertise to the table, but then looking at how we as civil society can organize and coordinate ourselves to create useful noise and influence positions. So going forward, what can be done differently? It very much connects to what Cindy spoke, because Cindy spoke about civil society communities at country level, accountability mechanisms, and all that. I think one thing is that we need to continue to push on the narrative that it's member state to member state. So you civil society, you have your corner there. We need to push on that, to push back, and to see civil society mainstreamed in these processes. And so that is both for the remaining parts, we are hopeful we will get an agreement, but also for the implementation. I think if we cannot continue to push now, the implementation will also leave us out. How can we ensure that civil society's accountability, voice, and participation in the implementation is visible and is present? So I think it's to start from the national level. I think the national level is very, very important because that's the relationship we have with the member states. The whole accountability is really about like social participation at the country level, and pushing, holding leaders accountable, making sure that civil society voices are heard. But for that to happen, that voice needs to be supported. Like we need to invest in that voice for civil society and communities to organize at country level for accountability. And I think the other thing is utilize existing mechanisms. Somebody mentioned about, for example, the Global Fund mechanisms. A lot of communities and civil society representatives who are pushing and participating in the pandemic accord are also participating in other global health institution processes. So how do we leverage on that expertise? The Global Fund is just one of those. So you have the Global Financing Facility, you have civil society sitting on Gavi, you have civil society sitting on the Pandemic Fund. How do we leverage those opportunities for a joint response, especially where you don't necessarily have like a PPPR kind of civil society group at the country level. It's the same civil society organizations that have been pushing for global process. I think that's very important. And then the other thing is to think about community leadership. I would say community-led data is going to be very important because when we now begin to look at implementation, and we are thinking about, where are our countries investing, where are countries defaulting, where are countries not doing what they're supposed to do. It's very important that there is that community-led data that surfaces the issues, the real issues, where equity is compromised, where investments are not going right. I think it's going to be very important around that, because that also ties with demand. We have to work on the demand side. Like when we have the medical countermeasures, we have the financing. I mean, we need the demand side because like the financing won't happen without the demand. We really are going to have to push to make sure that there are investments, in the processes and, as articulated in the agreed text so far. And so the demand side, we have to work on it. We have to invest in the demand side, which is, again, communities and civil society. Sustained advocacy needs continued investment. And the last thing is connecting all that with ensuring that we connect all the dots and connect it to also delivery of, like for us to be successful, we have to connect everything from global level, from all the agencies, all the way to the regional level, country level, but all the way to the last mile in terms of delivery. How do we set up civil society, community engagement plans and frameworks, at the country level that are supported, that's financed. I think that's really what I would say, what we can do better. And I think for the days in between right now, it's to ensure that we don't down our tools. Right now, I think it's a very vulnerable moment because momentum, when you don't get the agreement, momentum can win, but I think it's the time for civil society to really push so that we don't lose momentum. Back to you, Sam.
After this, I will cede my moderator privilege and turn to the audience, but I'll take it one more time. Rosemary, can you talk about the strength of the African group so far, and sort of like whether they'll stay strong or whether they'll just lean towards self-reliance and whether or how far that could go without multilateral support?
Yeah. So I think the first thing is to acknowledge we've had, our own challenges in the negotiation process. And when I say our, I mean the Africa group. Definitely, I haven't been a negotiator. I'm on the side of the civil society, but I know there have been challenges and many of us who've been participating know that. But I think one of the strengths is the ability of the Africa group to come together and have consensus on certain things within the agreement. And I think that's very fundamental. Previously, what happened is that every African country would go into the negotiation and really try to, push and all that. So I think coming together as a group has been very useful in terms of trying to build some consensus. I think some of the contentious areas, specifically on equity, when you think about benefits sharing, for example, when you think about intellectual property kind of conversation, the IP, when you think about that, even though you see equity written in the document and all that, but I think those are some of the most contentious issues, and that is where we need the Africa group to continue to be very strong, because that has been the experience, in LMICs in Africa, where those things haven't worked very well and have continued to expand the gap on the inequity of resources, inequity of medical countermeasures, even inequity in voice and power and all that. So I think it's making sure that the African group can continue to stay firm, especially on the contentious issues that they are pushing for, that the rest of the world might find a bit challenging, especially, when you think about some of the barriers, that are making those elements contentious, have to do with, with profits and so on and so forth. And it's very important that we continue to push for the language of no country should benefit from a pandemic, no agency should benefit from a pandemic, and so on and so on. So I think on those contentious issues, it's very important for the Africa group to stay strong.
Awesome. All right. We will now turn to the audience. Oh, I've already got one question. Prepare yourselves.
Prepare yourself. Thank you, Sam. Mary, I'll market care. USA, and I actually have a question for Cindy. Yeah, I'm really interested in learning a little bit more about how you made it understood. You work in Botswana. What does the pandemic report mean for you? Because, you know, it's another big international technical process, and it's far away from people's realities. And I think the devil is really in the details. If we, for example, we've been indeed working on pandemic or Article 7 on the health workforce. And so deliberately, the negotiators told us we keep the language general. We talk about the multidisciplinary health workforce. We don't want to single out a specific group. We know community health workers is important, but we don't want to single out a specific cadre because we want to make it as inclusive as possible. But that can also mean that it gets excluded, right? So we now need to move to implementation, and it's up to us now to go back to our countries and say, we need Article 7 to be implemented in a way that it works for community health workers. And so how do we work with communities, with community health workers at that level to help engage them really and have it owned by them so that they can go to the government and say, this is what you committed to in Geneva. This is now a binding international instrument. And so how can you as a government make this work for us? And how can we implement this article in a way that serves the needs of community health workers and communities, etc. So I'm really curious, how did you do workshops? Did you produce tools? How did you make this a live kind of thing, right? This big technical, international, yet another political agreement. And so how did you help to make that better understood? And especially now, how are we going to take it forward to get it implemented in a way that works for communities?
Okay. Thank you very much. Okay, thank you very much for the question. So we went through a process of coming through the pandemic accord or the treaty. And then we clustered our communities into cohorts or sectors. And each one of the sectors had to look through the document and identify gaps. Actually look at what the document provides for and what the current reality is. And how then do we bridge the gap between what is provided for in the document and the reality? And that gap is what formed our position paper or our advocacy position paper, where we now have to take all these itemized issues to government to say, for the pandemic treaty to work for Botswana, we first have to address these issues. We also did a simplified version of the treaty so that communities at different levels can begin to understand what it is about and what is in it for them so that there can be a process of buy-in. So basically, each and every community that we thought was important for them to understand the treaty, we simplified the language for them. We also used local language in relevant cases so that people can begin to understand what it is about. The good thing is that we have all gone through COVID and everyone is aware of the aftermath of COVID, or at least have experienced the pain through COVID. So it becomes easier to talk about something that people can relate to. And that is what was happening through the stakeholder engagements. And we went, we did not only have the stakeholder engagements in towns, we also went to villages where you would find, for instance, people who would not have much appreciation of what is happening globally. but we were able to take them through the process. And we were drawing from our experience using, for instance, treatment literacy approaches in the HIV response, how to engage communities, and that's basically what we did. In some instances, would come up with songs. In some instances, we'll come up with dramatization of what they went through and what they think, or how they think certain things can be addressed going forward. So we tried as much as possible to really simplify things for communities.
Any other questions in the audience? That's fine, I wrote some down myself, I'll take that privilege. But also if the panelists want to ask each other any questions.
Just wait.
Oh, yeah, okay, yes.
Yes, thank you so much. I'm from Botswana, so I'm not gonna put Cindy on the spot. Yeah, so it's for everyone. So I'm just sitting from my own corner as somebody who's in between advocating for community engagement and a scientist as well. But then I feel like we're at the risk of making a mistake. I don't know whether that's good English, of starting the conversation of community engagement, only listening to people who are also coming from a perspective of the big diseases. I would like to see a forum where IDNT, HIV, TB, malaria, and everybody is speaking and they have the same voice. Not, okay, I know we have to start somewhere. We have built systems in HIV and all that, but I've seen what had happened with TB as well. So I know while if we continue doing this, all these other diseases will just be talking from their small parts, right? And I think the community needs to be an example before we can talk about collaborating with the other side. Let's start our collaboration first, make sure that we bring the other neglected diseases up to be heard as well in this pandemic. Because at the end of the day, when it comes to pandemic, everybody, we just need to make sure that everybody is segregated and not other people are on top and they speak louder than the others. That's just me from the corner. Thank you.
Yes, an unfortunate byproduct of most of the global health funding going to bigger infectious diseases is that their civil society is much more supported and built up, which means that they have the people and the expertise to come to these forums, and other diseases don't have that. We'd love to find a way for governments to holistically fund global health and not just in silo. But usually if you suggest that gets met with, oh, well then we can decrease HIV funding. We're like, so hopefully we can find a way to do that. Any other audience questions? Oh, back to the panel.
Yes, perhaps I would like to go back to your point and your point in Botswana, because not every, in the case of health workers, not every country has a situation or an ecosystem where health workers and community health workers are already organized at national level. I think Botswana is a case where it is more advanced. India perhaps also more advanced, but not in Indonesia. In Indonesia, community health workers are not self-organized, so they are not. They won't be able to, not yet at least, do the things that they have done in Botswana. So right now, it's still very much a disconnected process between pandemic agreement, negotiation, national policy regulation and policy direction, and what's going on at the community level being delivered by community health workers. So I think as opposed to making pandemic agreement as the dividing element, I think what civil society can do is making it a uniting tool for member states, or in this case, national policymakers negotiate. And we in Indonesia, CISDI has been leading a process where, yes, we work in communities with community health workers on making sure that they can carry out their tasks. However, at civil society group, we try to widen the network as wide as possible so that each of the civil society organizations can give input together as a group and then provide that input to the government. So right now, our Indonesia negotiators, they have already accept our input in pandemic agreement. And also our input, our meaning civil society input into the WHO various positions in universal health coverage, primary healthcare, and so on. So I think there are heterogeneity that we have to address, because at one point in national position, then that is where the pandemic agreement can never become an agreement, because the difference in every country's needs.
I think just to add to the conversation, I think specific to Zambia, we have the same experience as Botswana. You know, when we're looking at COVID-19, because it was a situation that affected everyone. And there was a lot of response where private sector did a lot of, contribution, financing, material PPEs, every time our minister was receiving this every day, yeah. And post, of course, the pandemic, there were issues of accountability. Where did this material go? You know? So those are the questions, and agreeing to what I said before, and what my colleague has said, is around issues of accountability. How do we can talk investment, even when we may have missed the train in the negotiation stage, but we're still getting to the implementation. How do we actually, I think as Rose Mary did say, how do we make sure that we change the narrative and we push more around investment? Just going to the point on that, again, creating a silo where you're talking this pandemic, meanwhile we've got clear issues that are affecting people. This is where we still get back to frontline health workers. The frontline health worker would not separate or segregate because they are trained to save lives. So if we're talking NCD, or we're talking TB, or we're talking child mortality, diarrhea, and that's the reason why we're emphasizing that's the front line that needs to have all the information. And that's where the investment needs to be. Structures, yes, I do agree that we need to make sure that in terms of coordination, because you know what, sometimes we may fatigue frontline health workers because of the way civil society would actually sort of engage them. A number of civil society organizations would actually be speaking to the same frontline staff because of their different priorities. How do we actually harmonize and approach in a way that it's so multi-sectoral? We're not just bringing in health, we're bringing others. It's something that CARE has been able to support in Zambia when we're looking at nutrition health. So right from the structure, the district level and communities, we have these coordinating mechanisms that brings out all the different thematic leads, including the civil society, to ensure that we have information that is being collected and being used to make better and informed decisions when we're looking at the different health issues that communities are facing. So I totally agree. I think your point as you started, I really totally agree that we should just not be now when sitting in this meeting and we're saying it's pandemic. Yeah, but today, what are we exactly doing? What is that investment that is being brought in to ensure that we don't fall back? Again, we talked about how we sort of lost all the gain around HIV programming during COVID. It was almost like we went back 3-4 years looking at the investment we've done with HIV programming. And for Zambia, one of the other things, because of that same issue, post-COVID, we actually saw that the prevalence rate around adolescents on HIV went up. So what should we do? So we need to make sure that even as we're thinking about investment, let's not just concentrate on this one bit, but we really look at what is it that we can actually do to address all the health-related challenges at community level? Because this is gonna happen. We're talking climate change. Sometimes climate change, we just say there's floods, there's droughts, but when we look at climate change, it brings in flood, it means there's a hospital that is destroyed. That's it. But there's still somebody who is willing and able to support. So what should we be actually be doing to ensure that these frontline workers are well equipped, well motivated, and well informed? Thank you.
Thank you. I just want to compliment a couple of points that are made. Firstly, in relation to different community groups, for neglected tropical diseases, there is a general issue of support and actual existence of community groups. It depends on the type of disease, and it depends on the people who are living with or at risk of that disease. Some are migrant, transient, and or live in very remote areas. But I think your point is a good one. In what ways can groups come together? And there is a very good example, I think, in Brazil, where they have created a forum for infectious diseases, where and there's a very strong group there that works on Chagas disease, which is an ETD, and working with groups for TB and HIV. And I think there are some good examples. I think in relation to the treaty itself, this question came up, really, which is, what is the scope? What is a pandemic, disease of pandemic potential? And so we had a kind of discussion about to what extent do existing infectious diseases are part of that. And this point about the polycrisis that we're facing is, if you're looking at NTDs, over half of them are climate sensitive diseases. And a number of them are also pandemic prone diseases. So, if we look at dengue, for example, but even if we look at leishmaniasis and other diseases, we are seeing already the movement of both people and the vectors. And in places where it's already endemic, the seasons are becoming longer, people are being exposed in different ways, and also the geographies are changing. So we did say that climate sensitive diseases needed to be involved in this. The other point is to investments, which is, if you are making investments for a future pandemic, you have to recognize that you are working with people and infrastructure who are also challenged with existing infectious diseases. So I think one of the things that we were trying to say to negotiators is that there has to be space for and a recognition that investments that are being made in infrastructure and human resources for pandemics also need to be able to be used for existing health priorities. Importantly, because that is where the need is, but also, and it's not a phrase I really like, but people are always talking about, well, we need to keep these investments warm, because use it or lose it, which is true. But the reality is that if you are going to have the continued support of governments and people, you can't just have these things waiting for the next pandemic. They have got to be used. But also, if you want to use them in a pandemic, as you will be talking about, you have to build up relationships. You have to be working with the people. You have to be working with the frontline healthcare workers. You have to be working with civil society. You have to be working with scientists, all before a pandemic hits. And I think that this is one of the points that we're also trying to get across here, is that even when you're talking about a scope, and there was a lot of pressure to narrow the scope of this agreement, because they don't want to create precedents to cover lots of diseases for a variety of reasons. But nonetheless, you've got to include the diseases that are of pandemic potential, and that's wider than HIV and TB and some of the pathogens that we're talking about. It also includes antimicrobial resistance generally. We need new antibiotics, but also to ensure that those investments can be used for existing health priorities.
We have time for maybe one more audience question, and one has any, all right.
Hi everyone, my name is Aida. I'm from Indonesia. My name actually is Manipanda, and now I'm a lecturer in University of Indonesia in public health department. And I want to ask for integrating your idea, your insight, and we are producing healthcare workforce who sometimes also have their own stigma, have their own perspective on, sometimes also like, we don't know exactly what should be done because it is like the pandemic itself is new things for us. And if you may dream, what kind of curriculum or something that we can incorporate in our education system that might be beneficial to support the pandemic support. Maybe it will be beneficial also for us as a teacher and also our students.
Get back to, oh, sorry.
Well, sure. Earlier on, when I was talking around frontline health workers and what they really need to have, I did bring out a lot around training. One thing I think we'll all agree in terms of training, it's not very structured for frontline health workers. So definitely we want to call for structured training that is specific. There's definitely going to be need to change the curriculum, yeah, and be a bit more holistic in the way it's done. Right now, for frontline health workers, their training is actually dependent on the different NGOs that they'll be working. So what I actually see in terms of a question, what would be the content? It's very generally coming from the point of how do they recognize the early warning around the pandemic that should be included in that curriculum, and how differently can they actually be able to be the quick ones to respond, because this is new information, and that has to be inculcated in a much more structured, regularly checked. There is clear supervision to ensure that they know, because there are times when frontline staff, they'll be trained and there's no one to follow up to see whether they're really. So I would say that is where I see that training coming. An example, it may not be from a pandemic point of view, but the Zambian government, recognizing the kind of not well structured training, did introduce a community health assistant role, you know, where they actually set up a curriculum, and this curriculum would be training these community health assistants. These would be frontline health workers that are now graduated and integrated in the government systems, and they are given a 1-year training. And that 1-year training means after they do the training, they stay in the community at least for 2 years. So if we have a clearly structured training that includes aspects of understanding pandemics, what kind of information to be able to provide in terms of sensitizing communities, what should we be doing at the point of providing that support, response, care. If that is done over a longer period, and we can actually check that there's a commitment over the next 3 years that they are actually practicing what it is that they were trained, that is what we need to look at. And not just look at frontline health workers that we are sure that they know everything when they don't. But we need to support them, and that's the investment that we need to require around the training packages. I hope that's helped.
Just a quick addition to that. I second the answer of my colleague here, but also I think in relation to the pandemic itself, when the pandemic hit, community health workers and frontline workers did not know what to do and how to do surveillance and screening. So I think that, and in relation to Article 7, I think surveillance and screening needs to be the basic knowledge and skill set that has to, that community health workers and frontline health workers have. And for now, like seconding also my colleague here, to tackle diseases now, but also to be useful in the pandemic.
Thank you. I just wanted to add that we also have to, first of all, maybe to appreciate Tandi's point to say that that is why in our engagements, we talk about community engagement holistically and not disease-specific communities, because pandemic preparedness is about the community over and above diseases. So we also need to look at communities as a resource. I remember in Botswana when COVID started, the government started isolating people in hotels. And then our disease burden increased, and that could not be sustained. They started looking for community places like your churches, to isolate people. And the next level, as the disease progressed, now we were isolating in homes. So when we engage communities, they're like, we didn't even understand why it was necessary for government to put people in hotels. Because we have the capacity as communities to do isolation in our own way, provided you've given us the information. So I think it's also important to look at community as a resource to the extent that they can support government and alleviate some of the financial burden that comes with managing pandemics. I also wanted to pose a question to Rosemary. I don't know if I'll be able to make sense, but one of the issues that we encountered as we were engaging with government was that, for instance, the Africa bloc was going to negotiate as a continent or as a bloc. And therefore, you find that Botswana is saying we are unable to form a position until such time that as the Africa bloc, we have decided on what that position is. That also became a barrier in terms of how as civil society we can engage, especially at a country level, to say how best do we, going forward, how best do we manage such. I mean, it's a good thing that Africa can negotiate as a bloc, but at the same time, it shouldn't be a barrier, especially for us in terms of civil society engagement.
Rosemary, you got like 90 seconds.
90 seconds. Very happy to see you and to hear your question, and completely agree about the need for, I think, broader conversation on community engagement. So I wanted to point to the WHO resolution on social participation, because that's what WHO is recommending for community and civil society engagement. And I think, we can figure out what does that actually mean, how is it unpacked? And then to the question about community health workers and frontline workers in terms of training, the question, I think it also ties to the leadership and governance question about when a pandemic hits, what kind of information do leaders need in order to adequately respond to the pandemic? Because you could also extend that to say, when a pandemic happens, what kind of information do frontline workers actually need in order to adequately respond to the pandemic? And it will take you back to then what kind of preparation and training do you need to align to? So I think those are conversations going forward, especially when the pandemic is something that has really never been experienced. To the question of Africa negotiating as a bloc and how it either promotes or hinders progress, I think, Cindy, you really are speaking to the point of we need then to mobilize communities and civil society in all the countries. I think this is the value, like I couldn't have put it better. This is the value of having not just Botswana organized. We need this kind of organization in Kenya, in Zambia, because then Cindy can talk to Rosemary and say, please push your government. This is how we are going as civil society. Then the other person pushes in a different country. Until we do that, if there's no civil society, no communities talking to the government in Malawi, for example, there's no sense of urgency. I think that's really the value that civil society brings, a sense of urgency, and that we can advocate at country level to say, when you go to Addis for that negotiation, this is how our civil society in the region we are aligned. So I think there is a gap in there because this process has to be supported, like this really needs to be supported to enable that kind of coordination and conversations. And I think Botswana becomes a case study.
Great, well, seeing as my phone has not been blowing up, I don't think that they've come to a decision yet. Oh, they haven't. Well, we can check your phones right after this. So I'll just say, we've heard from all of our panelists, and it's clear that there are some governments that want to commit to change in words without actually shifting power. And we know from our own experiences that we can't meet the goal without having a strong supported workforce. We can't ensure implementation without accountability. We can't build a local manufacturing capacity and have it be useful without them having access to countermeasures to actually manufacture. We can't control access for people without public ownership, and we can't do any of it without money, and certainly can't do any of it without civil society leadership. So hopefully we can take all of them forward, whatever form the negotiations take as we go on. Thank you all.
You know what? So negotiating tomorrow.
We need to commit to that, which you have said.